So our next speaker is Professor Hasnain Ali Shah. He's MD Edinburgh, MRCP UK, FRCP Edinburgh. He's a professor of medicine and gastroenterology, Aga Khan University, Karachi. Visiting professor, Dow University of Health Sciences, Karachi, and Ziauddin Hospital, Karachi. International Regional Advisor for the Royal College of Physicians of Edinburgh, past head of the gastroenterology section, Aga Khan University, research interest, portal hypertension and chronic liver disease, more than 100 research articles in the peer-reviewed national and international journals. Holder of research from Higher Education Commission, Abbott Pharma and Ferozans Lab, Pakistan, awarded first prize for the best research papers presented at American College of Gastroenterology meeting in Seattle, USA 1996. Awarded Pharmacia Award for the best scientific paper published in Diabetes and Metabolism in 2002. Trained and mentored approximately 60 FCPS trainees in the gastroenterology at the CPSP, Pakistan. Please, sir.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. I'm having to sit down to talk because I injured my back during travel recently, hurt my back. But that's not a major impediment this morning. It's heartening to note the number of people in the full hall at 9 a.m. If this were Karachi, it's very difficult to wake up people at 9 a.m., get the ball rolling. But people in up north of Pakistan, Lahore and Punjab, start working early. And no more do they go to bed at 9 p.m. Um, the cars are still on the roads after midnight. It's quite uh, good to see that. I'm thankful to the organizers of the conference for having asked me to talk on this emerging uh, interest in an area of medicine which has gained importance over the past couple of decades, or maybe less than that. That is NAFLD and NASH. Um, if this were 25 years ago and a patient turned up with a diagnosis of fatty liver on the ultrasound, I'd say, oh, don't worry, just lose some weight, take less of fat in the diet, maybe vitamin E at times. Don't worry too much about it. But no more is the case now. We all know that NAFLD and NASH, as from the previous talk from the speaker, Dr. Bilal Hamid, it's a very worrisome condition in modern times. Um, and there's a need to determine uh, newer therapies, more effective therapies for NASH. Um, the first few slides are going to be overlapping between the first speaker and myself, the previous speaker, because we always start from the basics actually. And definitions, first of all, I'll just quickly go over them. That it's a state of macrovascular steatosis in the absence of significant alcohol consumption. This association with the metabolic syndrome, which is obesity, diabetes mellitus, hypertriglyceridemia, or hyperlipidemia and hypertension. When this moves on to some degree of inflammation, that is cytologic ballooning in the cells, mitochondrial damage, Mallory's hyaline deposition, scattered inflammation, pericellular fibrosis, it is now moving on to NASH, non-alcoholic steatohepatitis. And this can be sequentially talked about as NAFL going on to NASH, and then ultimately cirrhosis, which is fibrosis with or without a significant fat in the liver, formation of nodules, and the dreaded complication of hepatocellular carcinoma. So the conditions, apart from the metabolic syndrome, which are associated with NASH, that is jejunal-ileal bypass surgery, the metabolic diseases which are a bit rare in the population. And then we go on to the medications like imidrone, tamoxifen, and heart therapy, hypothyroidism, and alcoholic compounds the situation. A diagnosis is thankfully achieved by the non-invasive modality of abdominal ultrasound, which is relatively cheap, easily available, and easy to do. It is unfortunately operator dependent, and if the operator is not very good, then one can get error in the diagnosis. But in good hands, in good centers, the sensitivity for diagnosis in the range of up to 95% and a specificity of up to 85%. And it is more sensitive than CT scan actually. And the cons here are that it is difficult to do in the morbidly obese patient and may miss in cases of focal fatty change. Whereas in case of MRI, it can pick up fat even in the focal fatty change and is a better modality from that point of view. And CT scan, as I mentioned, uh, has a sensitivity and a specificity of a diagnosis which reaches around 95%. So are we really undermining the need of doing a liver biopsy, which is the gold standard of treatment? Uh, well, liver biopsy to achieve histological diagnosis is really limited now to research tools in most centers of the world, and, and patients do not accept a liver biopsy very easily just to diagnose fatty liver disease. But there are problems, obviously, with doing things non-invasively, but a liver biopsy may not be justified in most cases. So although it is the gold standard, as I said, it is limited to, I would say, just as a research tool mainly. So the management up till now is upon correction of the underlying risk factors and avoidance of factors that lead to progression of a disease and specific treatment strategies. Like, for instance, weight loss producing surgeries, pharmacotherapy, which I'll be showing just now, and weight losing surgery in the extreme cases. The medications which have been used to date, which have been used to date, are actually the insulin sensitizers, antioxidants, hepatoprotective agents, hypolipidemic agents, because most people have got evidence of hyperlipidemia, and then anti-TNF regimens. But now is the time to move on to newer therapies, because the treatment may not be effective 100%, or maybe even close to 70%. And this is the theme of the talk this morning. And once again, the definitions first. Microbiota refers to a community of microbes in an organism, and microbiome refers to both the microbiota and the collective genes and gene products of the microbiota, which evolve after the microbiota are disintegrated in the gut after ingestion. The GI tract of humans, as we all know, contains up to 100 trillion bacteria with up to 35,000 or more species of different bacteria in the gut. And some are good, some are bad. And the balance between the good and the bad bacteria will determine uh, if they can impact on the genesis of fatty liver or not. And the composition of the gut microbiota varies among individuals as a result of multiple extrinsic and intrinsic factors, like, for instance, diet, lifestyle, genetic makeup of individual, and the like. So if you move on to the treatments for NAFLD that target the gut microbiota, the first which come in line are the prebiotics, which are indigestible foods that promote the growth of beneficial GI bacteria through fermentation of the prebiotic into short-chain fatty acids. But there's no convincing data really in the literature which shows the benefit of these agents in NAFLD and NASH in the human subjects, and a lot of work has been done on the animals as well. If you move on to the probiotics, these are living organisms that are ingested and improve the mucosal integrity of the GI tract through the alteration of the gut microbiota. Um, as we will see in the next slide, that mucosal integrity of the GI tract is central to the genesis of these series of events which takes place and leads on to the syndrome of NAFLD and NASH and cirrhosis. And there have been several studies which have examined the effect of on the biochemical markers, inflammatory markers, the cytokines, and the histological improvement of NAFLD and NASH following a microbiota. But these have been on small number of patients relatively. If you see Dr. Bilal's talk, you're talking about 30% of the population in a setting, 40%, 20%. It means hundreds of thousands of patients we're talking about. And the trials actually enrolled 50 patients, 60 patients, very small uh, sample which have been targeted in research. So what this diagram shows is that the high uh, sucrose, high fat diet, which is central to the genesis of the NAFLD and NASH, and also the metabolic syndrome, uh, leads to the increase in the gut permeability, increased PAMPs, DAMPs, and the LPS, and the various factors which lead on to the production of NASH. There is, and this leads to more deposition of fat in the peripheral adipocytes. There's increased triglyceride storage, and uh, they are going to be increased LPS as well. NAFLD, the progression occurs when there is activation of TL4 and TL9 receptors. There is a Kupffer cell activation, which means that there's going to be activation of the HSCs with ensuing fibrosis and cirrhosis. There is choline deficiency, and the excess ethanol, which is produced by the bacteria, also um, enhances the genesis of fibrosis and fat in the liver cells. And there's the association of cardiovascular disease as well. So if we look sequentially, the presence of toxic bile acids, increased gut permeability, increased the serum ethanol, and gut microbiome dysbiosis will lead to the occurrence of NAFLD and NASH. Whereas if you go the other way around, if there's good diet and exercise, decreased dysbiosis, weight loss, and decreased FGF19, this is helpful in the treatment of NAFLD, and patient goes towards the healthy liver. These are the various studies which I looked up in the literature from the articles on pediatric population, which have looked at different biochemical, biochemical markers, liver function tests, inflammatory markers, histological markers, and markers of the metabolic syndrome like OMA, IER, etc. Some have, once again, they're on a very small number of patients, 50, 60 patients, which have, some have shown a benefit in some the parameters and some have not. So it's not really across the board that you see that the use of probiotics has helped patients with NAFLD. As we move on over here, even in the adult population, and not all patients agreed on a liver biopsy post-treatment. So all that we have is a diagnosis on ultrasound or non-invasive um, uh, markers following treatment, although the thing started with a liver biopsy. Patients were diagnosed to have NAFLD and NASH. So these studies again show that there have been improvement in some markers in some sets of patients, but not in others. And this is the use of non-systemic antibiotics like rifaximin, which we have used it right, left, and center in cases of encephalopathy, in cases of IBS, constipation. Uh, but in cases of NAFLD and NASH, the results have not been consistent. So one cannot recommend rifaximin as a useful agent in cases of NAFLD and NASH, although it has become a routine in cases of IBS and in cases of hepatic encephalopathy, although in different doses. Fecal microbiota transplantation. There's some evidence in the animal studies that this modality can be useful, but not so in the human population. Objectively, if you look at the outcomes like improvement in histological makeup, in the biochemical and inflammatory markers, although there might be individually some benefit. At the moment, one cannot say that it is a very useful modality of treatment in the human setting. Symbiotics are a combination of both the prebiotic and probiotics are an area of therapeutic research in NAFLD. A recent study from Italy used probiotics, and they showed that there was a significant improvement in TNF alpha, serum CRP levels, and histological features in the treatment arm. And once again, as you see, that there is a very small number of patients which were enrolled, 66 patients in total, and in two arms there were 34 and 32, with some dropouts, and there were patients who were refused a repeat liver biopsy. And this data shows that the two groups, that is symbiotic and the placebo group, were quite comparable in the baseline characteristics. And if you look at the pre-treatment and post-treatment markers in the two groups, that is placebo versus symbiotic plus the lifestyle modifications, there's a significant improvement in BMI, the liver function, lipids, the C-peptide levels, the inflammatory markers, and the HOMA-IR, which is a marker of metabolic control. So there's some ray of hope here. And also the NASH activity index, which is mentioned in the last panel, showed significant improvement in patients who were treated with symbiotics in this Italian cohort of patients. We move on to another data set from Iran in a collaborative study with Canada, where they used a symbiotic versus a placebo in 50 patients in total, and these are the baseline characteristics which are comparable. And what they have shown is that there was improvement in the fibroscan features of KPA, the steatosis, liver functions, the metabolic markers like the blood sugars, lipids, in symbiotic versus placebo group. And there was also improvement in the inflammatory markers, CRP, TNF alpha, and NF kappa. So as I mentioned earlier on, that treatments for NAFLD that use a fecal microbiota transplantation. People have used it in IBS, IBD, constipation, different neurological conditions, but data in the treatment of NAFLD and NASH is scanty and still needs to be evaluated further before one can comment much. So to conclude, we have looked at the pathogenetic factors like gut permeability, the role of Kupffer cell activation, the HSCs, and the role of oxidative stress, the hepatocyte inflammation and fibrosis, the activation of TLRs, and by the bacterial the products. All of this is occurring, and we really want to look at the treatment options aimed at targeting the gut microbiome or the downstream cells signaling, which would continue to be the therapeutic targets in the few years to come in the treatment of NAFLD and NASH. It is a competitive inhibition between the good and the bad microbiomes in the gut. If we can give them the good uh, microbiome, there is ray of hope that this condition will improve. Thank you very much.